Good afternoon. I'd like to call together the SCBC committee meeting for September 2nd, 2025. At this time, I will ask Carol Mick with the statewide benefits office to do roll call of SCBC members.
Yep. So here in person, I have Director Maxwell, Commissioner Navarro, and Karen Peterson. Logged in virtually, I have Secretary Gordon, Treasurer Davis, Deputy State Court Administrator Evelyn Nesselrode, and Controller General Miller. Is there anyone else that's here that I might be missing? If you could just raise your hand or just announce yourself. I did not. Oh, wait, I do see Director Stephen Costantino as well. Yep, we are good to go.
Okay, agenda item number 2, approval of the July 29th, 2025 SCBC meeting minutes. Hopefully everybody had a chance to review those. And a motion to approve.
So moved.
Got a motion. Can I get a second?
Second, Yvonne Gordon.
All right, so we have a motion and a second. Any discussion on the minutes? Seeing none, I ask all that is approved, say aye.
Aye.
Those
Aye.
against? Anyone looking to abstain?
Yes, Evelyn Nesselrode would like to abstain.
Minutes approved. We have the next on our agenda, we have agenda item number 3, which is a statewide benefits office director's report. I'll turn it over to Director Artis.
Thank you, Bill. All right, good afternoon.
Before you start, I just want to acknowledge the Lieutenant Governor who's now joining the meeting.
Director Maxwell. Good afternoon, everyone. My first update today is regarding 2025 Medicare open enrollment. The state of Delaware Medicare open enrollment for the special medical Medicare supplement plan will be from October 20th to October 31st, 2025 for benefits effective January 1st, 2026. Information on this open enrollment period is being communicated to retirees in a number of ways. The first being it'll be included in the Fall Pensioner Healthcare Newsletter, which is being mailed on September 29th, 2025. Open enrollment packets from the Office of the Pensions will be mailed on October 6th, 2025. Plan rates, frequently asked question documents, and additional resources have been uploaded to the Statewide Benefits Office and Office of the Pension websites, as well as the Highmark Special Medical Medicare Plan booklet will be posted to the SBO website prior to open enrollment and following publication of the 2026 Medicare Renew Plan document, which is expected to be released from CMS in late September. For legislative and policy updates, on October 25th, Governor Myers signed Senate Substitute 1 for Senate Joint Resolution 7, as well as Senate Bill 12, both which impact the SCBC and the GHIP. For just a quick reminder, the Senate Joint Resolution 7 directs the SCBC to utilize specific strategies and policies when interacting and contracting for pharmacy benefit management services to achieve lower cost and pharmaceutical drug benefits to the state. Senate Bill 12, also known as the Delaware Pre-Authorization Reform Act of 2025, strengthens consumer protections by reforming how insurers manage pre-authorizations for healthcare services, as well as for pharmacy benefit management services. This act also shortens the decision timelines for both urgent and non-urgent prior authorization care requests and ensures that only qualified professionals are making determinations, as well as requires the use of electronic platforms by 2027. The joint resolution will be added to an upcoming SCBC meeting agenda, and Senate Bill 12 will go into effect in 2027. Any questions on the legislative updates or on Medicare open enrollment?
I do want to let everyone know that Paul Baumbach has joined the meeting.
Thank you. All right, and my last updates that I have today are related to our RFPs. So I have 2 updates for today. The first is the Pharmacy Benefit Management PBM RFP. The intent to submit a proposal deadline was August 22nd at 11 a.m. The Statewide Benefits Office officially received 12 intent to bids from the following vendors: Affirmed RX, Capital RX, CVS Caremark, Empiri RX Health, Highmark Blue Cross Blue Shield Delaware, Lucy RX Health Solutions, Med Impact Healthcare Systems, Optum RX, Smith RX, Transcarent, Unified Labor RX, and Vivid Clear RX. All 12 vendors attended the mandatory pre-proposal meeting, which took place on August 25th. As a reminder, the deadline for the vendors to submit a proposal is Friday, September 12th at 1 p.m. For the second RFP, the Vision Benefits RFP, the intent to submit a proposal deadline was August 22nd at 11 a.m. The statewide benefits office officially received 6 intent to bids from the following vendors. The first is American Family Life Assurance Company of Columbus, also known as AFLAC, Aviva's Third Party Administrators, IMED, Highmark Blue Cross Blue Shield Inc., Metropolitan Life Insurance Company, known as MetLife, as well as VSP Vision Care. Again, these 6 vendors all attended the mandatory pre-proposal meeting, which took place on August 26th. The deadline for vendors to submit a proposal for the Vision Benefit RFP is Friday, September 19th at 1 p.m. And for the committee members and everyone's awareness, for all RFPs, the intent to submit proposal list is posted publicly on the State of Delaware Bids and Contracts website. This is managed by Government Support Services, GSS, under the Office of Management and Budget. Any questions on the RFP update?
Just one. You said 12 submittals for intent to bid for PBM.
That is correct,
How
yes.
does that compare to previous years?
So previous years, we had, I want to say it was about 5 or 6. Unfortunately, it's on this meeting, correct? Yeah.
So the changes we made incentivize more to participate.
Yes, absolutely. We do see a lot of newer vendors who had not previously bid on any state of Delaware contracts, as well as, to my knowledge, any other state contracts from our conversations with Willis Towers Watson. So definitely opened up the market to some newer PBMs.
Okay, great news.
All right, thank you. That's all I have for today.
We have agenda item number 4, and we have Commissioner Navarro here to give us an update on some trends that he wants to report on regarding GLP-1. So I'm going to turn it over to the Commissioner.
Thank you, Director Maxwell. As you can see from the title, these are trends for GLP-1 drugs, spend and use for the Delaware commercial fully insured market. If you go to the next slide. I only have 6 slides, so I'm told I have 10 minutes. So if anyone has any questions, I'd be happy to take those questions at the end. This is in the interest of everyone's time. So you can see what does the commercial fully insured, what's that comprised of? That's the large group and small group markets, and as well as the individual ACA market. So this has no connection to the state plan, but there is corollary often that what follows in this market, the state's pretty close. I will say that the state has a different, not better or worse, but a different risk pool, if you will, than the fully insured commercial. But again, we found that they're pretty close. So the overall premise of this presentation is to illustrate that the costs for prescription drugs specific to GLP-1s have not really gone up. The cost to the plan, there's a slide in a moment, I'll show you. The cost to the plan hasn't changed much. The cost to the actual consumer hasn't changed much. But the rebate is going up significantly. So what's unique about GLP-1 drugs, I think we've talked about this for months now, years perhaps, but it helps lower your blood sugar levels, reduces the rates for cardiovascular events, and helps people lose weight. And we have seen it, real success stories in my office and what we've seen across the country. But the GLP-1 drugs drove nearly half of the total increase in prescription drug spending nationally in 2024. So in the blue box, what I think is really important is our office. We have the Office of Value-Based Healthcare Delivery, which falls underneath the Department of Insurance. We collect data from the 3 big insurers, that's CVS, or PBMs rather, CVS Caremark, Express Scripts, and Optum RX. So they're the state's three largest pharmacy benefit managers. What's unique to Delaware is we collect data on a much more granular level, more so than any other state in the country. So I can tell you through our research and our data analysis that which drug, whether it's Zepbound or Wegovy, we can get down to the actual drugs. In many cases, the information in the past was collected in an aggregate sort of event or type. So we have this unique ability that no other state has. So I do credit our staff and my deputy, Tanisha, when we were coming up with this law, working with the General Assembly to be able to get that information in that level. So, and we're able to, it's not just GLP-1 drugs, we can identify drugs through their ID numbers. And we know the rebates from each type of drug. So if you could go to the next slide. Again, GLP-1s have more than doubled from 2023 to 24. Cost, again, like I mentioned earlier, is nearly flat. But due to higher utilization per member per month spending on GLP-1s has more than doubled. But still the total spend on GLP-1 drugs was approximately 6% of the total pharmacy spend. I won't read each line from each slide, but I thought that was pretty important. One of the things that I wanted to just briefly touch on, as you may recall, the drug Zepbound was recently no longer offered and due to state employees due to a formulary change. I'll say that really troubled me because I think what we've seen has happened in the past when the rebates change and the PBMs and the manufacturers have the ability to change the rebates. Oftentimes the formulary changes. So it's not the person's physician or doctor telling them what the best type of drug for them. It's actually the PBM. And that should never, ever happen. Happened to me. I take a biologic and I have for years. At one point it was Cosentyx, and then I had to, because of formulary change, not because my doctor, I had to go to Taltz, and most recently to Skyrizi. And these types of drugs have an impact on people differently. In other words, you have to have liver tests for your liver enzymes for these types of biologics. And it can have a profound impact on a person's well-being and health based off of nothing else than a rebate change. And so I'm really concerned about that. If you can go to the next slide. So the key takeaways, and this in the next couple of slides, are that the per member per month spending increased 137% from about $5 per member per month to about $13. But the plan payments net of rebates increased by 131%. Now, these increases were caused by, again, higher utilization, not increases in the cost of the scripts. So if you can go to the next slide, I think this one is really the most telling for me. As you can see in the bar graphs, in 2020, the plan paid about $399, the medium blue. In 2023, really didn't go up that much, up to $409. You can see the middle darker blue is the member paid per prescription. From $90, it actually went down to $86. But what's most troubling is the rebate, right? So it went from $340 to now $473, which is clearly more than what it costs the plan. And so if it's unclear where that rebate goes here for the state plan. It's crystal clear in this scenario that it goes back either to the PBM or to the drug manufacturer. So if the state, and again, I'm using this general graph, was to receive their PBMs at that rate, the state would break even or have a net profit. I don't know where that money goes. I can't tell you. I know at one point there was a discussion that we could be told, but we had to keep it, we meaning members of the SCBC, we had to keep it, it was confidential. And I simply said, if I can't tell folks about it, I don't want to know. Because I couldn't keep it confidential in good faith. So if you go to the next slide, this is the closing slide. This is just a question, it doesn't have to be addressed today, we can talk about it in the future, but would the SCBC support our office collecting and analyzing this data on pharmacy trends. Again, I cannot say with certainty that the state plan mirrors what the information I just gave, but I think it's pretty darn close. And so we would have a better picture as to, follow the money. I've been on the record for years talking about the difficulties we've had with PBMs. We are now examining PBMs, we meaning the Department of Insurance, and we found them to be truth challenged. We found them to skirt the rules a little bit, and I'm trying to be politically correct. They haven't been very cooperative. And so based off of the data that we were able to collect that no other state can, and I'm not patting ourselves on the back, it's just the way the process, when we originally designed it, it turned out, because we were getting data that was not really useful because it was in the aggregate. So just wanted to have food for thought if the SCBC would support our office collecting this information. We would be able to look at rebates, the cost of scripts and utilization. And I think it closely mirrors the commercial market. That's my presentation.
Thank you, Commissioner. Any members of the SCBC have any questions for the Commissioner regarding the information you just presented to the committee?
Commissioner, I just want to, maybe point out one thing, paralleling the commercial fully insured business to the GHIP. I think a lot of the parallels are the same in terms of magnitude of cost and magnitude of rebates. The one thing I think that probably jumps out is that on the GHIP side, I think you had a stat in one of the slides that said it made up 6% of the total pharmacy spend. And in the GHIP, it's more than 40% of the total pharmacy spend. And I think that's just the GHIP covering GLP-1 for weight loss, where probably in the fully insured market, there's much less coverage for weight loss and more coverage for diabetes, which has a more stable trend historically. So the magnitude of the dollars are bigger, but at the per script level, it's probably pretty consistent.
So for the folks online and maybe the folks in the audience, if you could just, I'm not sure if you already did this, but just tell me who you are.
I'm sorry, Brian Sigsel from.
You usually see him, he's from.
I'm usually on the.
Yeah.
Sorry.
I know you are.
Yeah, I'm sorry.
I borrowed your pen.
That's right, you did. Penn Brothers.
Yeah, but like I mentioned earlier, we don't know. It's different, the GHIP, because of the makeup of the employees, the folks who work for the state and their families. But I think that once if we're able to dig in to find out where those rebates go, I think everyone would be interested in that.
Yeah, more transparency would be great.
Karen Peterson.
Yeah, Mr. Chairman, the reason we're discussing this today, are we maybe considering making some changes to the PBM RFP? I know a lot of states have cut out coverage for weight loss, but kept diabetes covered. Some states have cut it out altogether because of the enormous cost. Are we looking to do something with this information?
I think he came to me and requested time before the SCBC, and he shared with me the materials. I thought they were timely. Similar to what you said, I've been to recently to the National Association of State Budget Officers, where states share their experiences, and a number of states mentioned that they're moving away from providing GLP-1s just for weight loss, but keeping the diabetes part of it. So it's ever changing. They're starting that process. Whether they're actually successful in getting it through their legislature or not, that's to be determined. But I think he wanted to bring the information because it's kind of pertinent as the increases, but also being clear as to the rebates. And I think Stephanie would like to provide a response as to where the rebates are coming with regards to the GHIP. Does that answer your question, Karen?
Yeah, it does. I just, and I mentioned this meetings ago, that we really should be looking at it before we get into the PBM contracts and such, that, maybe we don't take it away from everybody, but we charge a higher copay for weight loss versus diabetes or some combination. But it's just, it's killing us.
Yeah.
In terms of the cost.
So just to your point about charging a copay for weight loss, the way that the manufacturers, as soon as you start charging a copay, they take the rebates away from the entire population.
So then it actually becomes more expensive to the plan just by charging that copay. I'm not saying it's right. I'm saying that's the rules of the game that we're playing in right now. If you talk to other states, that's what they're being told as well. So, a good discussion, but it's really a bigger discussion about plan design and cost containment measures as to what changes we would like to make to the plan in general. And this is just one of multiple ones. So, Lieutenant Governor?
Thank you, Director. And just a question for the Commissioner. I think we often talk about coverage or no coverage, right? Black and white, but there are ways in which coverage can be deployed in order to maximize the outcomes we want to see, including the health outcomes, even if it is just a weight loss coverage, and sustainability for a patient and for a population, making sure that, you know, we can figure out what the extent of the prescription is, whether it's for a short time or whether it's a maintenance drug for the rest of someone's life. I think a lot of that is being tested in the commercial market right now. And you just told us you've got a bunch of data. And so I would love for us to see if there's an opportunity to understand potentially which folks are seeing, what kind of results folks are seeing, or which commercial marketplaces are putting other requirements on the, you know, for example, an alignment with the nutrition program or some other incentive programs. And I think all that's being tested right now, and whatever we can learn from the commercial market might help us answer some of these tough questions about how we deploy these drugs, not just for an immediate effect, but so we see that long-term chronic illness decline that we are hoping to see in our population, as well as manage our finances appropriately.
So that data is compelling. I think I've seen it firsthand. I haven't seen the actual, I should say, the data is not available yet, right? So we don't know that, you know, someone who's taking a GLP-1 drug is no longer, you know, taking high blood pressure medicine, right? And but we do know and have seen the results of folks who we live with every day, work with every day, or in the community, that it's successful. The thing is, we don't know about long-term side effects, right? But we also don't know about the savings potentially for other types of prescription drugs. So I think it's still kind of early. But I will say, to your point, we've already made some changes to the PBM RFP, right? And so we've already seen that we've got twice the amount of folks applying. That's really good news. I think that, you know, if we had the ability from the department to collect and analyze this data, it's to your point about why today we just got this. This data is going to be released to the public probably within the next day or two through a press release. So we just got it and we thought it was timely.
Thank you for sharing.
You're welcome.
Steve, you have your hand raised?
Yeah, just a question that does not have to be answered immediately. I'm just curious if in the contract language, not so much the RFP, but just the existing contract language, if we have any language that a certain percentage of the rebates collected have to go directly back to the state. And I'm only thinking of course, we got federal law behind us, what we do in Medicaid. But I'm just wondering if there's anything like that in the contract language. And if not, that might be something we consider as we move this process forward.
Thank you, Director Constantino. This is Director Harness, Statewide Benefits Office. So yes, in our current contract, the state receives 100% of all rebates on medications through CVS Caremark. So we do receive 100%, all rebates pass through to the state. And to answer, I think, an earlier question, just a reminder to the committee that as a requirement of the PBM RFP that was approved by the SCBC, we are requiring that the awarded vendor submit annually to the Office of Value-Based Healthcare Delivery the pharmacy template that's being utilized by the Department of Insurance for their commercial market. So we did put that into this RFP, and it is a requirement for the awarded vendor.
Yeah, so CVS has our template, and it would be a very easy thing for them to do.
Thank you.
Anybody have any additional questions for the commissioner?
Just one more point. Sorry, it was 10 minutes, but
All right, Commissioner, you get another crack at it.
the point of the data is that the net rebates, minus the cost, is essentially null. You know, that makes sense. I probably said it wrong, but, and we also require carriers to cover them if they treat obesity as a chronic condition, which I believe all but, one other state does. Just my friend listened online and passed that on to me. That was it.
Okay, thank you so much. Appreciate the information and, you know, if there's further action that this body needs to take, I would want to take one of the full committee's present to talk about your thoughts of giving it additional information in the future. Okay. All right, so it brings us to agenda item number 5, which is the proposal review committee composition. I'll turn it over to Stephanie with regards to our 4 RFPs that are currently or about to be released.
Thank you, Director Maxwell. Good afternoon, everyone. Stephanie Hardis, Director of the Statewide Benefits and Insurance Coverage Office. So we're going to be continuing the discussion today on the SCDC's proposal review committees for the 4 active RFPs, those being life insurance, pharmacy benefit management, vision benefits, and health data warehouse services. As you recall, at the July 29th SCBC meeting, the SCBC's legal counsel, the Department of Justice, provided guidance on the composition of the RFP proposal review committees, as well as overall subcommittee structure. So to support today's discussion, the SCBC's Deputy Attorney General, Michelle Wayland, is joining us virtually. And for the committee, following a review of the DOJ's legal advice, which was provided at the July SCBC meeting, as well as the language that is contained in each of the 4 RFPs that was approved by the committee regarding PRC structure, composition, and purpose. The chair, vice chair, and the statewide benefits office have come to the following determinations, which we will walk through. And again, the information provided today on proposal review committee composition is specific to the 4 active RFPs. The SCBC can, of course, change how proposals are reviewed for future RFPs that have not yet been developed.
Mr. Chairman, point of information.
Sure. Karen Peterson.
At our last meeting, we said we would come back to this meeting and have the SCBC discuss which way they wanted to go, which is why I was surprised to get in my packet a handout that says it's all been decided. Is that, we're not going to talk about what our options are?
So what you have before you are really 2 options. Being treated similarly is the life insurance benefit RFP and the PBM RFP. The other 2, if you read the material that says it is different than actually requiring every SCBC member attending the PRC. So that is the 2 different options that we're discussing today or putting before the SCBC.
Well, I mean, there are other options as well that are not being considered. And one, of course, is an opinion we received from the head legislative attorney who interprets legislation for the legislature. Of course, we're dealing with HB 282 in this whole thing. That's not even being considered, and my understanding it hasn't been shared with anybody, even though there was a request to share it.
Yeah, we don't go shopping for legal opinions. We did get an opinion who would represent and defend the SCBC if there was litigation.
We got no opinion in writing from our DHEs. Nothing.
Nothing.
Okay. To this minute, we've got nothing in writing. We've requested it. Representative Blombeck specifically requested it in writing for the last meeting and at the last meeting, and we still have gotten nothing. So we have nothing before us except they mentioned one court case, and I read that court case, had nothing to do with what we're talking about. And so, I mean, I just think we shouldn't be plowing forward based on incomplete information or erroneous information. And, I know we talked the last time about, if we don't do this, we might get sued. We might get sued for denying retirees and unions designees. That knife cuts both ways. But for us to just plow ahead with decisions that somebody made, I don't know who, we were supposed to make it at this meeting, it's just, I think it's just wrong.
Okay. That's your opinion. we discussed it in length. I heard from unions during the discussions of the PBM RFP that they would suggest all members of the SCBC participate and not designate anybody. So I'm hearing conflicting
And
information.
listen, if you want to do that, that's fine with me. If every member of the SCBC has to attend every PRC meeting and every subcommittee meeting, which is what you're asking us to do, then fine, I'll be all for that.
Okay.
I'm not. I mean, I simply couldn't.
Through the chair.
Sorry.
We'll just have comments.
Yes, sir.
Karen, you still more.
No, I just, I just think there's another side to this. As I read the other opinion, and I don't know why it couldn't be shared with everybody. It makes great sense. It cites several court cases, not just one. And their ruling is there's absolutely no reason that appointees can't have designees. So I don't know why that's being withheld from the committee, and what's wrong with getting the information out there.
Can I just comment or ask a question as well?
Sure.
I appreciate it. So I'm just curious how other boards, I mean, from the perspective of legal opinion, for those who are here, and I sort of share the commissioner's sentiments. I serve on 33 different boards and subcommittees total, some of which I cannot have someone represent me on, and others I can, and it's all based upon statute. It becomes very difficult for me also to attend the ones that require my presence. And so having a designee on some of them is extremely helpful in actually ensuring that the representation of someone in my position is there with the sort of fiscal knowledge. So I just say that, and then I guess my question is really centered around how other boards, commissions, committees, subcommittees function from a legal opinion perspective. We typically receive on other boards that I serve on, we receive that opinion, and sometimes a memo is then drafted, but it's not always everything is provided in writing. So just from that perspective, I'm not sure how we have performed in the past when it comes to obtaining legal opinion from our DAGs here on SEBC.
I would defer to Deputy Attorney General Michelle Whalen to provide a response.
That wasn't her question. Her question was, how do we respond? What is it we get, not what do they want to give? So
I can't speak to historic practice of the SCBC. This is Michelle Whalen, but the request was for a legal opinion. Whether that's in writing or oral is at the discretion of the Department of Justice. And the committee received a legal opinion from the Department of Justice on this issue from my colleague, and that is consistent with my own interpretation and that of several deputies have looked at this issue. In fact, all of us. So I can't speak to historic practice, but legal advice was sought and was provided and would be defended if this were litigated in some form or fashion. And I can confirm that the DOJ is statutorily authorized and required to represent this committee. Legislative Council is not, and as such would not defend, and we have confirmed, would not defend the opinion that was provided by an individual member of the Legislative Council in her individual capacity.
just a point of information, the SCBC hired outside counsel the last time it got sued. So I don't know about them having to represent us. But I think it's worth, we shouldn't be opposed to knowledge that the opinion from the lead legislative attorney cites cases to explain their position. I've got nothing in writing as a member of the SCBC for our DAGs. I mean, I sit here and listen to their opinions, one of which changed within 5 minutes, but I listen to it and I write them down. And, I mean, the last I heard, they said we should have just have 5 people from the SEBC on these committees if we don't want to get sued or violate FOIA. I mean, the opinion that the decision that they relied on in the one little note that I saw was a case that was about FOIA. It wasn't about what constitutes a committee. It was about the Henley Cape Henlopen School Board violating FOIA every which way from Sunday. You know, not advertising meetings, not having minutes, going into executive session for purposes not permitted by law. Had nothing to do with the question that's before us. And that is, if there's a quorum of the, and let me ask it this way, and maybe Michelle can answer this. If the governor appointed a blue ribbon task force to look at healthcare costs for employees, retirees, and he appointed every member of the SEBC and every member of the RHBAS, and then some other folks from SBO. Based on your opinion, that would be a meeting of that task force would actually be an SEBC meeting, committee meeting, or maybe an RHBAS committee meeting. But I mean, that's why that makes no sense. The composition of it doesn't determine what the animal is. And that's what this opinion, which is very well written and very well cited the decisions. And I think just ignoring it doesn't do us any favors. I mean, you know, as I said, I know we're concerned about maybe this would invite, you know, the lawsuit against us or something if we put it in the record. Well, as I said, retirees and unions can also sue for denying us a designate. So, you know, either way, you set yourself up. I'd rather have the information than not have the information. You know, the SEBC has not seen this memo. And I think that's a real disservice to the members of the SEBC. I don't know how you make a decision hearing only one side of an argument, which we don't even have in writing, by the way.
Lieutenant Governor?
Yep, I just want to make sure that the words we use are clear so that people listening understand what's happening. I heard a comment about outside counsel, whether or not we would engage outside counsel. What the Deputy Attorney General is telling us is that legislative counsel is not, but I know you understand it because you've been there,
yeah.
But I want to make sure people listening understand it, that they have declined to defend this opinion should it be litigated on behalf of.
Even if it's wrong.
No, legislative counsel has declined to defend their opinion on behalf of the SEBC. Should we get sued if we were to follow that memo and not that? So whether we hired outside counsel to do that, that's fine. But the person who wrote this will not.
It's not.
It
said that in the memo.
Correct.
Not representing us.
Correct. And, right. I want to make sure that's clear on the record. Secondly, I heard you say she, and now it is 2025, so I'm going to be real. You know, people can have any pronouns they want, but I'm very certain that the person who leads legislative counsel does not identify as she, her. And so it is likely not the lead person. It is a person. I feel they are all very valuable, but let's be clear about who provided it or not.
Senior legislative attorney, Division of Legislative Services.
Not head of the division, is what you're saying.
Oh, I don't think I said head of the division.
Okay.
I didn't know there was a division.
Perfect. So this is the division that represents, they serve as counsel for legislators.
I understand that.
Not for, right, but you said you didn't know there was a division. So there's a division and they represent legislators. They do not represent the administration. And so they do not represent us. And so my question to the head of our committee is, where do we go from here? Because we have advice of counsel, and to your point, we can go seek outside counsel. We have lots of different options. But this point is preventing us from moving forward and figuring out how not to cancel any more meetings so we don't get behind and so that we can move forward on these RFPs.
Yep.
And so what I would like to ask is, do we need to determine as a committee if we are willing to move forward and accept the advice of counsel In the same, we don't have the ability to opinion check. We can agree or disagree. We can find merit in council's opinion or not merit in council's opinion. But at the end of the day, we have to decide as members of this committee whether we are willing to follow the advice of council or disregard the advice of council and therefore take on the risks that come with that. And so I would like us to understand if that is the decision point we are at. If we are not there yet, that's fine, but we seem to be stopping here at every time we meet.
Well, Mr. Chairman,
Karen Peterson.
yeah, well, first of all, I would suggest that the other members of the committee have the benefit of seeing this memo and the court cases it talks about and the Attorney General's opinions it talks about versus one case that was cited by our DAGs that talks about a case that has nothing to do with what we're talking about. So I would like to err on the side of having the knowledge versus not having the knowledge before we make a decision. But the second point is we made a big deal about, well, the RFP, go through these slides. The RFP, says this is who's on the committee. No, it doesn't. It says this is who may comprise the committee. May, not shall, not must. We could have, the Three Stooges on the committee. Doesn't say that members must comprise the committee. So, I think that's the second place where we kind of get off the rails on this thing. It may consist of them, may or may not. Okay?
Mhm.
So we're not locked into that. But the other thing is, if you look at the court cases, and I've read all of the ones that were cited in this memo from the senior legislative attorney, and the cases say the determination of whether a body is a committee or a subcommittee is determined by its relation to its creating authority. All right, it does not make it a committee meeting just because a quorum of the SEBC serves on it. And in fact, there's one section of the law that talks about the Department of Elections, which consists of 10 people. I think it's 10 people. And it says in the law, a quorum of 6 members shall be required for the transaction of any business by the State Board of Elections. A meeting of the subcommittee, which is comprised of 6 members, does not constitute a quorum of the board under this section. So here we have a case where 6 of 10, they said, man, that's not the board.
Mhm.
But we're saying here, oh yes, it is the board. If you have 6 or more SEBC members, then that's the committee. And therefore, appointees can't have designees. That's what we're saying.
That's right.
So
I think it's extremely important that we sort of figure out a path forward. To the Lieutenant Governor's point, we seem to be sort of arguing over some things that actually this opinion, I think it's great that you went out and have this opinion, but they're not the individuals that will be representing us, right? So I think it's actually vitally important for us to, where we are right now, assess how we want to move forward, because we have several RFPs that are now delayed. And when we're delaying these RFPs, it impacts people's lives.
Mr. Chair, I've had my hand up for quite a while. May I be recognized, please?
Sure, Paul Baumback.
Yeah, thank you. There were some misstatements made that I'd like to correct. Actually, let me start. I want to thank the treasurer for pointing out the burden, the time burden of all of these PRC meetings, especially with the 4 coming up, and how it can be extremely disruptive. And that is the reason, that is the legislative intent. I can say this is the legislative intent of House Bill 282 because I'm the frickin' prime author of that bill. And this, the complete disregard for both the letter and the intention of House Bill 282 by the DAGs is very disturbing to me, which is why I requested that the legislature have an attorney look at whether this was the intention of the legislature and whether this opinion was consistent with the law. And for the DAG's opinion to say, oh, it being a public body means that we can redefine it from being a subcommittee to the SEBC as a whole, and completely disregard this section of the law from House Bill 282, which was affirmed by both chambers unanimously twice last year, is very frustrating. And importantly, this is something that should be available to each member of the SEBC. Furthermore, The attorney did not say that they would not defend this position. What they said, quote, "This opinion is not being offered as representation." It is the statutory job of the DOJ to support the SCBC. As the DAG last month stated in July, stated, she was offering her opinion, which the SCBC may choose to follow or not. There is none of this blackmail of, if you don't follow my opinion, the DOJ will stand and not defend you if a lawsuit comes up. That is complete BS. It is the job of the DAG and the DOJ to support the body that it is assigned to. So those are falsehoods that are being shared in an alarmist way. This is a second opinion. This is what Senator Peterson and I thought was going to happen during the month of August before the August meeting, was because of the questions of this Freedom of Information Act, a quorum determining it's a public body. Well, we already know statutorily that subcommittees of the SCBC are public meetings. It says that in the law. Okay, big whoop, we know that. The question is, does this change it from being a subcommittee or the full body? And that is where the second opinion, which the majority of this body has not seen yet, is very important information to share and have the committee see it. And what the treasurer points out of how burdensome having to attend each of those meetings is the reason that House Bill 282 says explicitly that the appointed members may designate people to attend subcommittee meetings that are not the RHBAS subcommittee, may appoint designees the same as those who are there by their position. This is something where we wanted, it was the legislative intent that the appointed members had the same powers as the non-appointed members to have designees for subcommittee meetings. That is why it's there, because it's necessary because of how burdensome all this work is. And for the DAGs to completely disregard that legislative intent and disregard that section of Title 29 is very disturbing and is important for the members of this committee to see and not have this legal opinion withheld from them. So I strongly urge the chair to put into the public record this opinion of the senior legislative attorney, her personal opinion viewed from the perspective of the legislature. I request that the chair put this into the public record as it bears on the affairs, the direct affairs of the SCBC and the path forward. And unlike our DAG opinions, is in writing. Thank you.
So I think you made a request to the chair, so I'll answer that. Based on legal advice I've been given, I will not be adhering to your request to post this alternative opinion. So I will not be doing that. We could put it to a vote if we want to put it to vote, so it doesn't seem like I'm being a dictator here as to putting a second opinion. I'd be curious how just a private citizen can get an opinion from legal counsel in the matter that we're talking about. Can anybody off the street go to legislative counsel and get an opinion? I'm curious.
Mr. Chair, if I may, I'd like to read Title 29 Delaware Code, Section 2507. No officer, department, board, agency, commission, or instrumentality of state government shall employ any person to act as attorney, counsel, solicitor, legal assistant, or other legal advisor to such officer, department, board, agency, commission, or instrumentality, except as otherwise set forth in this chapter. However, such special counsel may be employed by such officer, department, board, agency, commission, or instrumentality with the approval of the Attorney General and the Governor upon such terms and conditions as the Attorney General and the Governor may prescribe. And then it goes on for 2 more sentences. I would emphasize that my office has reviewed the legal opinion offered by the Legislative Counsel in her individual capacity, and it does not change our legal opinion or our advice here, which is to protect the best interest of the SCBC should litigation ensue.
Lieutenant Governor.
Just briefly, it appears that my statements may have been misinterpreted, and so out of an abundance of caution, I would just want to clarify my statement, which was not that the DOJ would not represent us. Of course, they would continue to represent us. Of course, disregarding their advice in a public meeting would not be great for litigation, but they would represent us. My statement was that legislative counsel could not and would not represent us, and that was the representation of legislative counsel. I believe the use of just pronouns was referring to the attorneys. I'm talking about two different entities here, and I appreciate the Department of Justice would stick with us through thick and thin. Thank you.
Thank you, Lieutenant Governor. And it was confirmed with the lead attorney of Legislative Counsel that in fact they would not defend the position that was offered by the attorney in her individual capacity. Although they may have been aware of it, they would not defend the SEBC in litigation.
Mr. Chairman, I think we've reached the splitting hairs part of this meeting, where we're getting into who can and cannot speak to us about the law. You know, like an attorney whose job it is to interpret legislation. Now we're saying, we can only use the DAGs. Well, I've read what the DAGs wrote. I read the court case, and I think they're wrong. I'm not an attorney, but I do have legal training, okay? And I can read plain English. But now we're getting into the he or she and and they're not going to represent us. She never said she would. She said she wouldn't. She doesn't represent us. So I don't think we need to be splitting hairs on this kind of stuff. I'm more interested in making the right decision, because this could affect. I mean, if they're dead wrong, we're following them down the path of dead wrong. We have brains. We can read these things, and we can make decisions ourselves. You know, a lot of us have written laws for years, have interpreted, have enforced laws for years. We're not idiots who have to just follow a DAG who decided for whatever reason they think we shouldn't have designees. And I think it's wrong. And I mean, she gives an excellent example. I'd like to hear the response to this excellent example besides the Department of Elections, where they said it does not create a board meeting. This whole example about the House Veterans Affairs Committee that is comprised of a majority of the members of the House of Representatives, right? And that's not considered a meeting of the House of Representatives when they meet. It's a meeting of the House Veterans Affairs Committee, even though a quorum of the House are members of this committee. I mean, I don't know how you distinguish that.
Isn't the House exempted from open meeting laws under FOIA?
No, that was my bill. Brought the General Assembly under.
I think you should talk to the
My
General Assembly about their view of that then.
I'm sure I have for many years.
The treasurer and I have both asked if there's a decision point here. And quite frankly, Director, we can litigate ourselves and we can argue the law, but I do not feel prepared to disregard the advice of counsel, whether it be correct, which counsel has guided me well before, or incorrect, which I have been misguided by counsel before.
Me too, for 45 years.
Ma'am, I listen to you when you talk, and I would prefer if you would listen to me when I talk. At this point in time, we have to make a best interest decision. And like I said, the treasurer and I have asked if there is a decision point. I don't know if that is the next best step, if there needs to be more time. But the question is isn't whether the DAG is right or wrong. The question is whether it is the will of this committee to follow the advice of counsel or to not follow the advice of counsel.
Thank you for that. And so based on the advice of counsel, we put forth in this presentation two ways to handle these RFPs, considering that there are 4 of them and that some folks will say it will be a hardship for people to be able to participate on all 4. And so as Stephanie was going to go through her presentation before we got into the discussion about alternative legal opinions, the life insurance benefit RFP would require all members of the SEBC to participate, and it would not allow for the 4 appointed SEBC members to appoint a designee to those, but would have to serve for themselves. Similar path forward with regards to the pharmacy benefit management RFP. I will stress that I heard several times as we were crafting this RFP, that a member would be, going forward with regards to participating with themselves. And so the other path forward would be the vision and the health data warehouse RFP, which at this point in time, I would defer to each member of the SEBC whether they would participate on that, so they would have a choice. But then again, the caveat being that if you were an appointed member, not by virtue of position, you would not be allowed to have a designee sit on that proposal review committee. So does anybody have any questions, given that a lot of our time is talked about legal opinions and the like? Any questions from committee members?
You need a motion.
I would like a motion to proceed with the RFPs as stated in the presentation set forward.
Yeah, motion.
We have a motion. Can we have a second?
Second,
Second by Secretary Gordon.
yes.
Any discussion on the motion?
I'm sorry that I did go through this and, what we just transitioned, we took a hard left and transitioned right into the vote. So can we just take a minute to go, or I don't know, Ms. Hartos, were you gonna have more of an exposition? I know we're sensitive on time, but I'm curious. I think one of my questions is the PBM and the health data warehouse are, man, they affect everyone, right? They're system wide. The other two are opt-in, and I don't know if that affected the decision about I don't know if there's an opportunity to tier these in any way where we might be able to have more options, but that's my question. But I think everyone would benefit from a brief overview.
Absolutely. So for life insurance, as you all know, this PRC has already been active. They've already convened once to conduct vendor interviews. There are 2 finalist vendors, Securian and MetLife. This has been announced to the SEBC previously. However, the subsequent meetings were canceled due to the current discussion. So in order to maintain a contract effective date of July 1st, we are at this point moving forward with the 4 appointed designees who, per legal advice, should not have been designated for those positions will be removed from that proposal review committee. Therefore, appointees on the SEBC are welcome to serve in their place. Again, the only item that's been conducted thus far is the vendor interviews, which we are happy to coordinate a second interview for those SEBC members, should they be interested in scoring. Again, I just want for the SEBC's awareness, the proposal review committee and the scoring process is not the final results of all RFPs. The SEBC still has to review and approve the recommendation for all RFPs. Specific to pharmacy benefits, I believe Director Maxwell touched on this a bit more. There were some comments requesting that all SEBC members serve themselves. However, again, I just want to stress that, per what's in Title 29 of Delaware Code, as well as what's in the RFP, the 7 non-appointed members, those serving by virtue of their position, are still permitted to name designees. For vision and data warehouse, for those RFPs, again, just with comments we've heard at the last meeting regarding the heavy workload for the 4 appointed members who cannot name designees. This was an option for the SEBC to consider to reduce the PRC to alleviate that burden and that workload for those members. To your point as well, life and vision are supplemental benefits. Health data warehouse is also not a benefit. It's not a member-facing benefit. However, of course, it does structure all of our claims and our reporting out to the committee. So if there is interest in maybe having a smaller PRC for vision versus having the full PRC size for health data warehouse, that is absolutely an option. I think it's really up to what the committee is comfortable with. If they are comfortable pulling back a few seats in that review process. And again, I also just, want to stress that whether you have one individual reviewing these RFPs or these proposals, or whether you have 100, the results should be the same.
Okay.
The SCBC developed the scoring criteria, the criteria weight, the mandatory requirements. So regardless of who is reviewing, whether it's 5 PRC members or the full 11 or whatever that review process looks like, the recommendation and scoring results should be the exact same. So I think maybe that'll help some committee members understand that while, there are some PRCs where you more want to be involved in, if the will of the committee is to decrease the size, you don't necessarily have to be involved in every single procurement. These are incredibly time consuming, of course, especially as we're seeing higher number of bids come in, of course with PDM, but also across the board. Vision at 6 was a little bit higher. Last year with employee assistance program, we had 7, which was higher than what we had seen previously. So the time commitment is going up. There's, of course, that opportunity to alleviate the review process a bit. I hope that
That's helpful.
that
Can I
answered your question.
do all questions together and then I'll be silent?
Sure.
Thank you. One is for Director Maxwell, Ms. Hartos. Are there any opportunities within these 4 to push our process back at all as to stagger these committees to alleviate some of the burden for those who would not be able to appoint designees is my first question. And my second question is to Ms. Whalen regarding is there a distinction in the Department of Justice's perspective between the retiree appointees who are appointed as retirees and a class of individuals versus Representative Bomback and Mr. Tafner, who are appointed by virtue of their position being enumerated in the statute? Or are they viewed as the same 4? I would argue there is a difference between Representative Bomback and Mr. Tashner, but I'd be interested to understand your opinion on that.
We believe it would be all 4.
Thank you.
Mr. Chair, my hand is up.
Stephanie's finishing up. I think she had a second
Thank you.
question, but you're next.
Yes, thank you, Lieutenant Governor. To respond to your first question of whether there's opportunity to delay or stagger these PRCs more, quite frankly, no, we've already delayed this process significantly. These implementations are very robust, and especially when you're looking at benefits like vision, pharmacy, there's transfers of prior authorizations, prescriptions, there's, educating members on changes to formulary where.
I understand. I just wanted to make sure it was clear whether we had an option or not.
Thank you very much. Unfortunately, I would very much say we do not have the opportunity to push these back any further. Thank you.
Paul Bomback.
Thank you. Mr. Chair, since you have chosen to not share this opinion with the members, I'd like to just read the intro and the executive short answer. If a subcommittee of the SCBC is comprised of a quorum of the members of the SCBC, is the subcommittee de facto the SCBC? Short answer, no. Quorum is a procedural tool used in
I'm not gonna allow Mr. Bomback to read the opinion. If he wants to circulate it with members, or if you're curious as to what it says, I specifically said I wasn't gonna share it at the advice of counsel, so I'm not gonna take up the rest of the members' time with that. When is our next RFP?
The next RFP being released would be the health plan TPA RFP, and we're scheduled to start developing that RFP in October.
October. When would we finish?
I believe April 2026 for release in May of 2026 at the absolute latest.
And Director Maxwell, we did in our last meeting discuss that there would be an opportunity to take a different approach moving forward for RFPs that had not been approved by the SCBC.
That is correct.
Thank you.
I have 4 sentences I would like to finish reading.
I'm not entertaining that now. As the chair. All right, so we have a motion, a second. We have a lot of discussion. I'd like to take a roll call.
Director Maxwell,
Yes.
Lieutenant Governor Gay,
Yes.
Commissioner Navarro,
Yes.
Karen Peterson did leave. Secretary Gordon,
Yes.
Treasurer Davis,
Yes.
Director Stephen Constantino,
Yes.
Deputy State Court Administrator Evelyn Nesselrode,
Yes.
Paul Baumback. He left, and that's it.
Did you? Did you get it?
I said yes. That's my bad.
Awesome, great.
Director, just before the vote closes, did anybody indicate a proxy if they weren't able to be here?
Yeah, it was Evelyn Nesselrode. I don't think Bill Overly has the ability to
Okay.
proxy anybody or Jeff Dashner.
Thank you, Director.
So receiving enough votes, the motion carries. So it brings us to the next agenda item. I think we turn it over to Willis Towers Watson. I'll turn it over to Brian Stitt.
Thank you, Director Maxwell. Brian Sitzel from WTW. If okay with you and the committee, I'd like to change the order a little bit of the financial discussion for a couple of reasons. One being that the Q4 financial reporting is predominantly given for background information and also has an executive summary in the July fund report. And the July fund report is comparing July results against a budget which hasn't yet been approved. So I thought it made sense to go over the budget
Okay,
first.
great.
Jumping right into the budget, I would continue to view things as sort of 5 key categories that we typically review: enrollment, premium contributions, other revenues, claims, and other expenses. High level from an enrollment standpoint, based on July actual results, the GHIP has seen about a 2% year-over-year increase. I know the note off to the side says FY23 to FY25, meaning FY23 over FY22. So it's really a 3-year run. In our projections and in our budget setting process, we continue to and have historically used a 1% annual growth rate in GIP membership. So something we may want to consider changing down the line. You'll notice that membership is down July. The numbers in red are actual July enrollments are down versus June. That's simply because of the termination of the University of Delaware from the active coverage. And then you'll see in highlighted blue and white font, the University of Delaware terminating Medicaid participants beginning January 1st of 2026. Outside of that, nothing extraordinary relative to enrollment. The proportion enrolled in each of the 4 different plan options is fairly consistent to what it was in FY25, with just a very, very slight shift in enrollment out of First State Basic into the PPO, but pretty much uniform enrollments across the board in terms of option election. From a premium contribution standpoint, we basically have 3 groups: state employees, state pensioners, and non-payroll groups. State employees' share of premium contributions are equally administered through the payroll system, which happens twice monthly. And in terms of how those premium contributions hit the fund, it is basically a lagged 1 pay cycle. So the amounts, for example, hitting the fund this July really represent the second half of June's payroll contributions and the first half of July. So there's a 1 pay cycle lag equally between the state share and the employee share on the state employee side. On the state pensioner side, there is a 1-month lag in the state share. So again, the amount hitting the July fund is actually the state share for pensioners paid for June's premium contributions, whereas the pensioner share is current, meaning July is hitting in July. Non-payroll groups, as we discussed, the University of Delaware exited effective June 30th of this year, so just before the start of FY26, with the Medicare eligible participants terminating on a calendar year basis. So their last date of coverage would be December 31st of calendar 2025. The University of Delaware was lagged 1 month and that they were basically paying in arrears. And they made up the lion's share of the non-payroll groups. So UD, using that same logic and example, was paying June's premium contributions in the month of July, July's in the month of August. The majority of the remaining participating groups, they're either what I would call current, defined as current, meaning paying July and July, August and August, or actually paying in advance, where they're paying July's in June, August and July. But again, you'll see in the results on the non-payroll groups, a big decrease in premium contribution revenue and other revenues, just simply because the University of Delaware was upwards of 2/3, and in some pockets, 80 to 90% of the non-payroll groups share of costs. In FY25, the GHIP collected a total of $1.26 billion in premium contribution revenue. As the committee is aware, the 4.2% rate action that was approved for FY26, full FY26 from an active and early retiree standpoint, and calendar 26 or half of FY26 from a Medicare eligible retiree standpoint, which is why you'll see over here, bagging my mouse, but a slight bump up on the active side in July and then another bump up in August. That's due to the one pay cycle lag, and then it basically levels off other than for anticipated enrollment growth. Same thing happens on the employee share. You can see on the pensioner side, we don't see that bump up, that 4.2% rate action until August because of the 1 month lag on the state share for the pensioners. And then relative to the non-payroll groups, because they're all either current or in advance for the most part, we're seeing that bump up immediately happening in July. And then you can see going back to the Medicare side, you can see a bump up happening in February because of the 1 month lag, because that rate action doesn't go into effect until January of 2026. So with the 4.2% rate action and the lags that we just talked about, and the fact that the University of Delaware has terminated from the GHIP, total premium contribution revenue for FY26 is actually projected to be lower than FY25 at roughly $1.2 billion. Other revenues, basically made up of four key components: EGWP revenues, which are numerous different payment streams, but all specific to the EGWP, and then prescription drug pharmacy rebates, both on the commercial side and on the EGWP side. Relative to the EGWP revenue stream, we have it broken down between three different components, all with different timing. The direct subsidy, which makes up the primary funding of Part D plans. So you're receiving a monthly subsidy payment from the federal government due to your people being in the EGWP part of Medicare Part D. The prescription drug manufacturer discount program used to be called the coverage gap discount program. Essentially, the manufacturers providing discounts for certain drugs flowing through the EGWP. Low-income subsidies, so participants who are at a certain level of the federal poverty limit are both eligible for premium subsidies as well as coverage subsidies, and the federal government reimburses through the EGWP for those subsidies. And then the federal reinsurance program, which is there to protect against excess catastrophic claims. We receive information directly from CVS in terms of these amounts. The Inflation Reduction Act had a significant impact, some to the positive, some to the negative, depending upon which of those key components we're talking about. But overall, in the aggregate, very positive impacts to the GHIP. You can see in terms of the direct subsidy in calendar 2024, the GHIP was receiving roughly $16 per member per month in the direct subsidy. And then the Inflation Reduction Act significantly increased those amounts. because of the expansion of coverage under Medicare Part D. You can see that amount ballooned all the way up to $108 per member per month. At the time we set FY25 budget, it was expected that future direct subsidies would be relatively flat or with nominal increases. The national average bids were recently released, and we saw another significant increase in the direct subsidy, which is a positive impact to the GHIP, going up again from $108 per member per month, all the way up to $159 per member per month. So almost a $16 million increase on a calendar year basis. And the GHIP receives those monies on a monthly basis. In terms of the federal reinsurance program, the Inflation Reduction Act moved it in the other direction, so we saw a decrease in the expected federal reinsurance payments. Starting in 2025, went down from $91 to $70. The GHIP receives these amounts in two payments. One is a prospective payment, which is a fixed amount per member per month, which is meant to be a subset of the total federal reinsurance payment, and then a year-end reconciliation happens typically 12 to 15 months after the end of the year. The GHIP has received the reconciliation payment typically in January of each year. So the amount that you would receive in January of 2026 would actually be for calendar year 2024. In terms of calendar 26 expected federal reinsurance, you can see the amount's a little bit higher, $73 versus $70. One of the bigger differences is that the government increased the prospective payment, a big jump up. It had decreased a lot from 24 to 25, and then it's going back up from $30.41 per member per month to $47.92 per member per month. And that's the amount the GHIP receives on a monthly basis, prospectively, again, with that year-end reconciliation. In terms of the manufacturer discount program, this is another component that also is seeing a decrease from calendar 24 through calendar 25. There's a typo in the exhibit. The right-hand box should read calendar 26, not calendar 2025, but a decrease in that component from a high of $98 in calendar 24 down to an expectation of $76 for calendar 2026, or about a $6 million decrease again on a calendar year basis, noting that all of these will impact FY26 for basically half the year, half of FY26. But in total, all of the EGWIP revenues are going up pretty significantly year over year, an increase of about $9 million expected from calendar 25 to 2026. So positive results in terms of additional revenues coming into the GHIP, offsetting the claims and expenses of the GHIP. And again, these are just the roll-ups of those total revenues. The other two components we didn't talk about were the rebates, the commercial rebates and the EGWIP rebates. You can see a big increase in expected rebates on the commercial side, from roughly $110 million in FY25 to $161 in FY26. That's primarily due to the formulary change, removing Zepbound, being replaced with mandatory Wegovy, which comes at a higher gross cost, but also comes with higher rebates. So,
Can you say that again, sir?
yeah, so effective July 1st, participants who are taking GLP-1s for weight loss will now only be able to get Wegovy. And
You gave an explanation.
the formulary change on the CVS Care side.
You also mentioned rebates.
And the rebates for Wegovy are higher than the rebates for Zepbound. So you're seeing both an increase in the gross cost, because the retail price of Wegovy is higher than the retail price of Zepbound, But the rebates for Wegovy beginning 7/1 of 2025 are also higher than the expected rebates for Zepbound, such that the net cost to the GHIP, gross cost minus rebates, is actually lower. The Wegovy net cost will be lower than what the prior Zepbound net cost was. And we're also seeing a big jump in rebates just because we're seeing a big anticipated spike in utilization of GLP-1s.
Thank you.
So more spend produces more rebates.
Just a quick question, Brian, on
Yeah.
other revenues, you
Yep.
can see in participating group fees that with the departure of UD, I think. We're
That's
being
right.
significant. Are there any other revenue categories where UD had any substantial impact on those?
Substantial, no. I mean, obviously you were getting rebates from
Across all.
UD enrollments in the commercial plan and the EGWIP, but not anywhere near the lion's share of people under either of those two plans. While they were the lion's share of the participating groups, they weren't the lion's share of the GHIP. But you're right, that's the primary reason why the participating group fees are going down in FY 26 because of that 5% risk load that's no longer coming in from them. And then just pointing out in the last column, which is other revenues, which is sort of a catch-all of everything else. You'll see in FY 25 there are a few different blippy items, generally not anticipated. So in July of 2024, the beginning of FY 25, there was a missed performance guarantee, which falls into the other revenue bucket. The September $7.3 million payment was the payment back to OMB from the cash shortfall coming out of FY 24. There was a missed performance guarantee in January of 25, which goes into that $392,000 number, as well as an EGWIP settlement, and then another missed performance guarantee in June. But those are items that we don't generally anticipate when we set budget. But overall, across all different other revenue components, we're expecting a big increase from roughly $281 million to $362 million. In terms of claims, our claim projections, recall back when we set our updated trend assumptions, we're projecting that active and early retiree medical expenses are projected to go up by 8% per year. The medic fill trend was increased to 6% going forward. And then we had that very big, it's in the appendix, the number is 39%. Yeah, we have it in here. Yeah, so for FY 26, 38% on the commercial pharmacy side from a gross standpoint, and 33% on a net after rebate standpoint, predominantly driven by GLP-1s, and then an 11% gross trend and a 9% net trend on the EGWIP side, which are all factored into the claim forecasts, which basically are made up of those three components: the underlying trend assumption, the 1% enrollment and growth, and then the University of Delaware terminating from the GHIP on those two different dates. So in total, claim expenses are projected to grow from FY 25 of roughly $1.4 billion, 1,387.7 to nearly $1.5 billion for FY 26. And then from an expense standpoint, we have a number of different expense categories. Program and ASO fees, so generally amounts charged by the carriers to administer the programs, and you can see the various components that make up program and ASO fees. Office expenses generally cover salaries, benefits, postage, supplies, what's listed here. And then we separately break out expenses for the EAP, data warehouse, consulting fees, over administration, and ACA. And these all show what assumptions we use to project them for FY 26 and beyond for the long-term projection. But generally either fixed and set by actual FY 26 contract language, expected to remain flat due to contracts or generally expected to grow by inflation. And in terms of total dollars relative to expenses, we're expecting expenses to be lower in FY '26, mostly because of the exit of the University of Delaware. Total, again, premium revenue, premium contribution revenues, and other revenues make up the income side of the equation, and claims and expenses make up the expense side of the equation. For the full fiscal '26, we're expecting just under $1.6 billion in operating revenue, again, premium contributions plus other revenues, and little north of 1.5 billion, 1.548 billion in terms of claims and other expenses, for a net total fiscal '26 projected income of just over $41 million. And when you add that to the fund equity ending balance as of June 30th of FY '25, which is not shown here, I think that number is roughly $96 million. We have it in another slide. The fund is expected to end FY '26 in a cash positive position of just under $140 million. That's $137.7 million. And net of reserves, roughly $75.8 million. So projected to be in a good cash and reserve standpoint position by the end of FY '26. In terms of long-term projections, recall that when the 4.2% rate action was approved for FY '26, it was under the 3-year smoothing approach. So assuming that there would be approved 4.2% rate actions equally in FY '26, '27, and '28, with FY '29 having a singular projected rate action to get to a $0 deficit after reserves at the end of FY '29, currently standing at 14.9%. All based on the trend and enrollment assumptions that we previously discussed. And that really ends the FY '26 budget discussion, so I'll open it up to questions.
Questions of community members? Seeing none, so we need to take some sort of approval, right? Of the budget.
That's right.
What page will we work off of? 21? 21? All right, I'll entertain a motion for operating expense budget of $1,548,000,000. As seen on page 21.
This is Stephen, so moved.
I have a motion, can I have a second, please? Second,
Second, this is Colleen.
any discussion on the motion? None, all those in favor say aye.
If there's a question.
There's a public comment opportunity at the end of the meeting. Thank you.
All those in favor say aye. Aye.
Aye.
Those opposed? Those that would like to abstain? Motion carried.
So moving on to the actual July results for the beginning of FY '26. These results are compared against the FY '26 monthly budget that was just approved. So you'll see the July budget is expected to generate roughly a $25 million loss for the month. That's just simply due to the fact that Some of the other revenue components, particularly rebates, are lagged. So we see flippiness from month to month in terms of either income or losses. Relative to premium contributions came in very close to the expected budget number of $100,411,000. You can see highlighted on the black rows, the top half of the charts represent the actual results with the bottom half representing budget. You can see fairly across the board that all groups came in relatively consistent with the total budget expectations, other than the non-payroll active group came in a little bit higher at 4.8 million versus 4.4. But all in, actuals for the month of July came in very close to budget. You see that relatively across the board. In terms of other revenues were roughly $850,000, also better than budget, partially due to a higher than expected direct subsidy for the month coming on the EGWIP side, and a formulary true-up payment not expected coming in from CVS, but from another revenue standpoint, you can see most components for the month of July came in fairly consistent, if not a little bit better than budget for the month. Similar theme in terms of claims. Claims came in almost exactly on budget for the month, only $400,000 different out of the $126 million claim budget for the month of July, with active employees coming in a little bit worse than budget, about $1 million over the $85 million budget. Early retirees or pre-65 retirees coming in about $1 million better than budget, and Medicare retirees coming in almost exactly on budget for the month. But claims in total, 0.3% different than budget. So pretty spot on to budget. Similar story on the expense side. Expenses coming in a little bit worse, higher than budget by a couple $100,000, predominantly due to higher than budgeted consulting fees. You can see most of the expense components are budgeted to be equal in each month, but we do see blippiness based on just timing throughout the year in terms of how the actuals play out for the year. But in total, results for the month of July were $1.7 million better than budget. So overall, a good start to FY26 compared to budget. We do have a long-term projection in here, but it's the same long-term projection that we just reviewed in terms of setting the budget. So the long-term projection is not updated for that slight variance to budget for the month of July. And then the one last piece in terms of July results that we should discuss is the GLP-1 experience. Recall we were anticipating a very large increase for FY26, an increase to an expected total FY26 expenditures on the weight loss side of 136.7 million, and on the anti-diabetes treatment side, 37.7 million. You can see that actual July results actually came in somewhat significantly lower than anticipated, a decrease of 15% against June of this same year, not shown. And we believe that's just simply a timing impact of the change over of the formulary from Zepbound to Wegovy. We expect utilization to spike back up in August, but we'll certainly monitor that on an ongoing basis. Any questions on July results? Carol, I'll turn it back over to you.
Okay.
All right. Thank you, Director Maxwell. This will be a relatively brief presentation. So Our open enrollment results for fiscal year 26. This is an annual overview that the statewide benefits office puts together to demonstrate the movement across benefits and plans as a result of annual spring open enrollment. For the purposes of this presentation, the University of Delaware was excluded from the June 2025 totals. The reason being, of course, that large separation of about 7,000 active employees or active members and then the 3,000 retiree members does skew the results of the actual movement of our attributed members across the plan year. And we wanted this analysis to be reflective of the current GHIP membership. So to review the highlights on the executive summary slide here, overall, we saw minimal increases in enrollment across the non-Medicare health plans. Highmark saw a slightly larger increase than Aetna, which does follow the trends we've been seeing over the past few years with a slight decline in Aetna's enrollment. We also saw a slight decrease in enrollment to the dental plans. The statewide benefits office, we have been hearing from members concerns regarding the provider network of our dental plans, particularly in the Dominion dental plan. We're looking forward to working with the SCBC to address any upcoming dental plan procurement, which will begin in the spring of 2026. We are also very happy to see increases in enrollment to our supplemental benefits. So that would include the accident and critical illness insurance coverage we have, Group Universal Life, as well as the FSA and pre-tax commuter programs. We have seen significant increases in those from fiscal year 25 to fiscal year 26. The SBO had increased targeted communications related to these benefits, as well as trainings to try to improve enrollment of these programs. So really excited to see that those increased communications and trainings from our office have been paying off, and we're seeing an increase in subscribers for those benefits. Next slide. This slide just breaks down a bit percentage-wise what we're seeing in changes from 2025 open enrollment to 2026. Again, reflective of what we reviewed on the prior slide, slight decrease to the Delta as well as a larger decrease to the Dominion dental plan enrollments. And again, seeing that significant increase in our security and accident and critical illness enrollment programs, as well as Group Universal Life and the ASI Flex, which administers pre-tax commuter benefits, as well as the FSA program. And that's really all for this presentation today. There are appendices included in this deck, which breaks this down a little bit further by benefit and by plan if you're interested in reviewing it in greater depth. Again, this is more of just a high-level overview to see what we're expecting and what we've been seeing across plan changes throughout our benefits. Any questions from committee members? Yeah.
I appreciate you presenting the data. Are there any key takeaways or inferences? I know it's early, but that you'd like to share with us to guide our work going forward?
Yes, absolutely. So I would say indicative of the results we've been seeing here, as well as what we've been hearing from members, I think our dental benefits, I would encourage the committee when we're developing that RFP over the next few months to really put a focus on provider network and even potentially performance guarantees related to the provider network. Especially, like I said, the Dominion Dental is our more lower cost dental plan. And especially with specialty care for dental, we've been seeing issues when members cannot find a specialist dentist in the state and are forced to travel to either Philadelphia, New Jersey, or Maryland. And unfortunately, I will say that's known to be an access issue across the board. Delaware ranks 50th out of all 50 states for dental access. I know that's something that the Delaware Healthcare Commission and a few other bodies have been working to address, as well as, try to bring in some of those individuals graduating from dental schools in the Philadelphia area. So in general, I think there needs to be a large focus on that dental procurement and really securing that provider network and maybe tightening some of the performance guarantees with whoever the awarded vendor or vendors are for that benefit.
Thank you.
Quick question.
Absolutely, yeah.
Commissioner?
Have you seen dental providers no longer taking Delta and Dominion because the reimbursements are so low?
Yes. There has been feedback from some providers regarding the reimbursements, changes to reimbursement structure, as well as my understanding, not grandfathering the rates from previous providers to newer providers. And again, similar to our contracts with Highmark and Aetna, we do not contract directly with the providers and we're not privy to the details of those contracts. So we can't necessarily push what the reimbursements rates can or should be for those providers. But I think that's something in the RFP we can, similar to what we just did with PBM, get a little more in the weeds of what we would require to be within those contracts for administration under a plan.
So the dental communities is telling the department that they haven't seen increases for 20 years. And it's really hard to operate on those dollars today from 20 years ago.
And I
So
think
I'm
that
just-
we don't typically get feedback directly from the dental providers, but I
Yeah.
would understand that that's what we've been seeing from some of our patient feedback we've been getting from our members.
So we making an effort to try to, whether it's through the RFP process or not, to see an increased reimbursement for the dentist? Is that on the agenda?
Again, unfortunately, the FCBC does not directly contract with the providers, so we cannot independently increase the reimbursement. That is something, if there's interest from the committee to attempt to push within our current contracts, because even though we're procuring for this benefit next year, it wouldn't be for contracts effective until July 1st of 2027, so about 2 years from now. So again, this is something I'd have to take back and look a little more into. But again, we don't directly contract with those providers, but that's not to say that there couldn't be more direct pushes with our current contracts to try to work that in.
So on the non-state plan, the loss ratio for dental plans is somewhere in the 60% range. States across the country have upgraded that or updated that. We're going to be looking to do that in Delaware as well, hopefully next year.
Great to hear. Thank you.
So question for you, I noticed school districts, because they don't choose usually those two providers, right? They usually can go out and have their own plan. Like, do we know who they're choosing? Are they choosing others besides Delta and Dominion?
Yeah, that's a great question. You're correct. Some school districts do offer different benefits, not all to my understanding, but for our teachers or K through 12 enrollees, they typically have an option to enroll in our benefits, or if the school offers differently, they can choose that as well. We have not done research with those schools to see the other vendors that they are working with, but that's absolutely something we can take back and look into.
Yeah, I'd just be curious, because if there's a problem with these two, that the reimbursements are low and it's not covering the cost, I'd be curious as to what those other vendors are experiencing, because they're in Delaware for the most part.
Yeah, absolutely. We can definitely take that back and I think build into our discussion with this RFP when we're developing it over the next few months. Thank you.
All right. Does anybody have any other questions? If not, we're on to public comment.
I don't have anyone pre-registered for public comment. Is there anyone in person? Anyone in person today? No takers. All right. Steven,
Steve has his hand up.
did you wanna?
Sorry, I was a little late on that one. Just on the dental, to piggyback off of Commissioner Navarro, I know we don't have direct insight into those contracts, particularly because we pay for it, the employee pays for it. But one of the things we could do in the RFP is to make sure they really confirm network adequacy, and have a very, a good definition on what network adequacy is. We kind of do that in Medicaid.
I will start with first person. Hello?
I think that's my end went down.
Oh,
Can you hear me?
I can hear you. Can you please state your name for us, please?
Yes, my name is Dale Swain.
Okay, you have 3
And-
minutes, Dale.
Okay, my comment is in regards to the appointed members. The legislature, in rare fashion last year, voted unanimously with both parties to shake up the composition of the SEBC because of concerns over how it was being run, the lack of transparency, et cetera, et cetera. So the 4 appointed members
began working with the SCBC, but it is very, very concerning when you hear at various meetings, especially this one, the director seems to be treating those members as second-class citizens. They're fine to sit at the meeting as long as they sit there quietly and shake their head at the appropriate time. I really am incensed at how Karen Peterson and our former legislator, Paul Bombach, was treated today. It does not show that they are equal members of the SCBC, and it is very, very unfortunate how the director is treating them. It's my comment, it's my opinion, and I stand by it. Thank you.
Thank you very much. All right, and then I have Rebecca Scarborough next. Rebecca, you should be able to unmute your microphone now. Are you able to now, Rebecca? Is there anyone else logged in virtually? Please raise your hand if you would like to make a public comment. Give Rebecca another minute. If you're unable to unmute yourself, Rebecca, you can always send a public comment to the SCBC at our email address, scbc@delaware.gov, and that is sebc@delaware.gov. I will skip down to Nick.
Hi, can y'all hear me?
I can hear you.
Okay, yeah, my public comment, or rather request for clarification, is does the budget that the SCBC just approved include that projected budgeted amount of 136 million for weight loss GLP-1s? Just so I'm clear. That's my public comment.
Thank you very much. Is there anyone else that would like to make a comment today? I still see that Rebecca's still having some microphone issues. I don't have anyone else. Director Maxwell?
Okay. All right, is there any other business to come before the committee? If not, I'll entertain a motion to adjourn. Easy one, guys.
I move that we adjourn. Yvonne Gordon.
Second, all right. All those in favor say aye.
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 Opposed?
Aye.
Motion carried. Thank you. Have a good day.